Multiple choice question number 1.
A 42-year-old male presents with severe epigastric pain radiating to the back. Laboratory findings show elevated serum amylase and lipase. CT scan reveals necrotizing pancreatitis involving greater than 30% of the pancreas. He is hemodynamically stable. What is the most appropriate initial surgical management strategy? A. Immediate laparotomy and pancreatic necrosectomy. B. Early ERCP with biliary stenting. C. Aggressive IV fluid resuscitation and supportive care. D. Prophylactic broad-spectrum antibiotics. Or E. Percutaneous drainage of necrotic areas immediately.
Correct answer is C, aggressive IV fluid resuscitation and supportive care. Early management of necrotizing pancreatitis focuses on stabilization with fluids, pain control, nutrition, and monitoring. Immediate necrosectomy, A, increases morbidity and is delayed until necrosis becomes walled off, 3 to 4 weeks. ERCP, B, is only done if biliary obstruction or cholangitis is present. Routine antibiotics, D, are avoided unless infection is confirmed. Percutaneous drainage, E, is reserved for infected necrosis or worsening clinical status.
Multiple choice question number 2.
A 60-year-old smoker presents with persistent hoarseness for 3 months. Laryngoscopy reveals a unilateral vocal cord paralysis. Which location is the most likely cause? A. Thyroid gland. B. Aortic arch. C. Trachea. D. Esophagus. E. Carotid bifurcation.
The correct answer is B, aortic arch. Chronic hoarseness due to left vocal cord paralysis is most commonly caused by compression of the left recurrent laryngeal nerve as it loops around the aortic arch, typically from a mediastinal mass such as a bronchogenic carcinoma. Thyroidic tumors, option A, can affect the nerve but usually present differently and less commonly cause isolated chronic hoarseness. Tracheal compression, option C, rarely affects the nerve directly, while esophageal pathology, option D, is a less frequent cause. Compression at the carotid bifurcation, option E, is anatomically too high and lateral to involve the recurrent laryngeal nerve. Therefore, mediastinal involvement around the aortic arch is the most likely explanation.
Multiple choice question number 3.
A 70-year-old male with atrial fibrillation presents with sudden severe abdominal pain out of proportion to physical findings. CT angiography suggests mesenteric ischemia. What is the next best step? A. Exploratory laparotomy. B. IV heparin initiation. C. Percutaneous thrombolysis. D. Colonoscopy for ischemia confirmation. E. Broad-spectrum antibiotics only.
Correct answer is B, IV heparin initiation. The immediate management of acute mesenteric ischemia involves initiating anticoagulation with IV heparin to prevent further thrombus propagation and limit intestinal injury. Surgery, option A, is reserved for patients who develop peritonitis or bowel necrosis, making stabilization the priority. Thrombolysis, option C, can be considered later, but only after the patient is stabilized. Endoscopy, option D, is not indicated initially and may delay essential therapy, while antibiotics, option E, are supportive but not the primary treatment. Thus, prompt anticoagulation is the critical first step.
Multiple choice question number 4.
A 35-year-old female presents with a 3-centimeter breast mass. Mammogram is inconclusive in dense breast tissue. Which imaging modality is most appropriate next? A. CT scan breast. B. MRI breast. C. Ultrasound breast. D. PET scan. E. Stereotactic biopsy.
Correct answer, C, ultrasound breast. For a breast mass in dense breast tissue, ultrasound is the preferred initial imaging modality because it effectively differentiates between cystic and solid lesions and can guide biopsy if needed. CT, option A, is not recommended for primary breast evaluation.
while MRI, option B, is typically reserved for high-risk patients or when ultrasound findings are inconclusive. PET scanning, option D, is used for staging known malignancies rather than initial diagnosis. Biopsy, option E, is performed after appropriate imaging characterization confirms the need for tissue sampling.
Multiple choice question number 5.
A 55-year-old patient with long-standing GERD is found to have Barrett's esophagus with high-grade dysplasia. Best management? A. Long-term PPI therapy. B. Radiofrequency ablation or endoscopic mucosal resection. C. Surveillance every 6 months. D. Partial gastrectomy. E. Fundoplication alone.
Correct answer, B, radiofrequency ablation or endoscopic mucosal resection. High-grade dysplasia in Barrett's esophagus requires definitive endoscopic eradication therapy, such as radiofrequency ablation or endoscopic mucosal resection, to prevent progression to esophageal adenocarcinoma. While proton pump inhibitors, option A, are important for controlling reflux, they do not treat dysplasia. Surveillance, option C, is appropriate only for non-dysplastic Barrett's esophagus. Surgical interventions like esophagectomy, option D, are not first line for high-grade dysplasia, and fundoplication, option E, addresses reflux symptoms but does not eliminate dysplastic tissue.